and just give you some basics and information concerning peptides and using them for nerve pain, neuropathy, and just specific uh, pain syndromes that you guys run into the office. And I'm going to tell you that I think I have a considerable experience in using a lot of these peptides and working with uh, different types of presenting pain, neuropathic, and so forth. And I'm going to tell you that I really believe that um, pain is really a relationship. It's a neurogenic type of inflammatory process, and it's immunogenic, meaning initially it may start off as a peripheral nerve uh, stimulation. It goes through that cycle of that unmyelinated C fiber is activated and releases like substance P or um, any any of the other related nerve factors in that area, um, like the calcitonin related peptide, things like that, that activate this process of a little bit of bradykinin release, and they start stimulating in a potential immune response in this peripheral area. A signal is sent out the dorsal root ganglion into the spinal cord, and it also invokes an inflammatory response at that dermatome level. And remember, there are macrophages like microglial cells and monocytes that can be activated, and you'll find specific to this pain activation, these cells are upregulated and can be upregulated and can be sustained, where initially a peripheral nerve stimulation starts this pain process, but the immunogenic side of this takes control and proliferates this pain response. And that's how we get into this process of prolonged pain, chronic pain. And I think it's just fascinating. If you understand these pathways and know the process, there's a lot we can do with treating this. And I'm going to tell and just you, as you will too. I mean, I'm hopefully I'll give you some information tonight that it's going to make a huge difference in how you practice. And I think, the patient has to be kind of set up for that also. Why is there, that peripheral nerve stimulation that sets off that secondary immune response? There's a reason for it. And it could be a multitude of reasons that we're all familiar with, of what can go wrong with the gut, the brain, and so forth, of which we're not going to get into, but how the immune system can actually, what's happening is you're hyperactivating the innate immune system. And what's really important is, I think, to understand that as this pain starts propagating, this pain process, and the cycles continue, you're going to eventually get an exhaustion of these neural growth factors. And that is what continues to lead to more problems with chronic pain. And so I think with just starting with that, without really getting into much more, I think what I'd like to do is, just like I did it down in the second peptide meeting we had, international peptide meeting. I'm going to go right to it, because this is what everybody wants to know. They're like, okay, doc, what are we doing to treat this pain? Well, I'm going to give you just a couple simple things that I think are going to be your go-tos to treating neuropathic pain. And I'm going to tell you, in the past, I've been very successful using thymosin beta-4 and BPC combined. I use them together, injecting right in the area of pain, 900 micrograms sub-Q, and of the thymosin beta-4 and BPC 800 micrograms sub-Q. And I'm going to tell you specifically, it can be cervical, it can be lower back, it can be ischial pain from chronic hamstring issues. This is going to be something that you're going to just do subcutaneously in that area, but you're going to need to maintain that, and it's going to be a daily process that might go on for anywhere from 2 to 6 weeks, and it may take you a couple of days before you catch up, but you're going to see definitely some significant responses, especially if it's more neuropathic, and in that chronic setting. And remember, I think it'll make more sense when we get into the details of this. There are a couple of mechanisms that the thymosin beta-4 and the BPC are helping us with, and one of them is the BPC is working in the on the interleukin 1 beta production, decreasing that production, which is coming from the microglial cell and activating this chronic pain cycle. So from the immune side, it's keeping this pain channel, a new one that I'm going to show you exists, that keeps this pain cycle progressing. And thymosin beta-4 is, I think, very important in helping to regulate that. And then we get into these issues within the nerve and the axons about these actin filaments, the G-actin and F-actin, which are very important in keeping the transport of neural growth factors and keeping the structure of the dendrites and the axons and everything, pretty much the structural aspects of the nerve working at its highest function. Just as an aside, I've used thymosin beta-4 and this BPC just in the same dosage where I've had some really significant peripheral nerve or carpal tunnel issues, where people post-surgically have come in with significant secondary hyperesthesias, neuropathic type pain, post-surgical, that I've used this injecting just right around the median nerve, where I've had some tremendous results in decreasing that type of pain, that hyperesthesia type of pain. And also I've had some significant improvement in sensory nerve function, in bringing back some of the sensory nerve. And that's remarkable. And I continue to see that, and it's really amazing to be able to do that, where I'm going to tell you 10 years ago, I didn't have the ability to do anything like that. And I took a lot of people to the operating room. I'd do grafts. I'd wrap grafts around the median nerve. I mean, all kinds of things you do surgically, which I rarely do now. But that's an aside. Let's get to cerebrolysin, which I think for all of you, this would be my go-to in pain management for everyone. For any complaint of any specific cervical pain, lower back pain, shoulder pain. I mean, this has just been an incredible neuropeptide that I've been able to utilize in the office, one-time injection, and then into some therapy or whatever for any type of issues like this, where I've resolved so many different types of pain. I mean, post-operative issues, chronic pain, 10 years out, 5 years out, 2 years out, just amazing, where I've specifically taken, it's usually about a cc of cerebrolysin, and I'll inject it, not sub-Q, but pretty much I'll go IM into that area of pain. Say it's in the trapezial area of the neck, or in more of the cervical musculature, where they have those, if you want to call them the Janet Travell type of trigger point areas. You just find the area where they're just most sensitive, and everybody's going to be able to show you that. And you inject a cerebrolysin, and you'll tell them that it'll be 1 to 3 days. Most people, it's within a day, and then the others, it's about 3 days. and you're going to see some remarkable results of pain improvement. And that can be explained. We don't have time to go through this whole thing as I did before, but in Florida. But remember, I told you this is about exhausting all the neural growth factors. And cerebral lysin is it has the brain-derived neurotropic factor, the nerve growth factor, the ciliary neurotropic factor, and the glial cell derived neurotropic factor. And those are all specific and important in modulating pain signaling within the axon and within the nerve itself. So this is very important, and so what you're doing is you're working immediately on negating the initial pain substance P that's being released, or the calcitonin related peptide, and you're stopping that right in its tracks with the cerebral lysin. And to some extent, you're doing that with the TB4 and the BBC. But specifically, you're doing that, but you're also following up with these growth factors that are going to work also within the dorsal root ganglion. They're going to work within this dermatome level within the spinal cord, and they're going to work on the microglial activation. And I'll get into that in a little bit, but I showed you a couple pictures here, but what's really happening is that microglial cell, the immune cell, is activated and producing those chemokines and proteases and cytokines, more specifically, tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, and those have an effect on the astrocyte. And remember, the astrocyte it's helping regulating neurotransmitters, and it's real important if the microglial cell keeps it initiates the process. Okay, the immune system initiates this process, and then this astrocyte is what continues this chronic pain process because it stays activated, and it controls this process, and that can be that can actually be followed if you with some of the factors that the astrocyte produces, and as far as this glial, I think if I remember right, it's a glial fibrillary acid protein, and that's something that people will follow in studies and looking for activation of this astrocyte, and to see how specific and to what extent the chronic pain process is. But that's kind of how it's followed, but pretty much straightforward about how the immune system activates this process. It starts with peripheral nerve, activates the immune system to some degree, and it stays on. And so we're all about turning it off, and cerebral lysin has been an incredible tool for me in treating all kinds of issues with people with chronic pain. And I'll tell you that typically the way that I do it in the office is I'll see them and I'll inject that area specific with 1 cc, and then I'll see them back in a week to see what their response is. And I'm going to say over 90% easily have their pain almost 100% improved, if not 90, 95%. And you will get a few that say, doc, it lasted a day or two, it was really great, and then it came back. And then I elect to give them another injection. And at the same time, I'll put them into PT, I'll have dry needling. I mean, there's all kinds of things you can add. Remember, this is the art of how you people and what you do to improve their function. And I do think you have to add people are deconditioned. With another issue I want to get into with cerebral lysin is that the AMPK activation of the muscle. So you are kind of resyncing that muscle too, and improving the action potential to the muscle. So you're getting it to work appropriately again. And that's why therapy is important with this process of getting the function back in the muscle, because that's a big part of this process. But I just wanted to kind of give you the basics and give you that notion that, guys, got to give this a chance. Cerebrolysin, I think, can be an absolute game changer for you and how you treat your patients and how you continue to follow up with their pain and treat them. Could it be done daily? Of course. But I found that just one injection and then follow up once a week. And yeah, there's some people I've seen for 5 weeks. There's a lot of people I see once or twice. I think you'll be really impressed with the results you see from that. Then there's, as you see, I have the HAAOD. That's another, that's a hyaluronic acid with the growth hormone fragment AOD, which is the repair fragment, and also fat loss fragment. But it is also used to treat pain just in the same, again, it's a 0.5 cc sub-Q or IM injection into that trigger area. And I've had success with that too. That's something, really, it just depends on, what, I guess what you feel more comfortable with and what makes the most sense. I like kind of using the HAOD for issues that are more, I want to say, if it's more like Achilles tendon involvement, things where I'm trying to also nurture the tendon because of the hyaluronic acid. So there are reasons that I use that, and more for repair with the AOD if there's involvement of tendon or ligament, so forth. But I'm going to tell you that cerebrolysin is amazing for just real neuropathic pain. Okay. And then I bring up this new peptide, this ARA 290, which is 1 milligram daily sub-Q anywhere. And we'll get into this. This is a fragment of erythropoietin. And this is really gonna, I think, give you some interesting information as to what more knowledge we have of pain. So neuropathic pain, spontaneous burning electrical pain, allodynia, you all know, it's increased sensitivity to non-noxious stimuli like intolerance to bed sheets. Used to be some things that people just didn't think existed, but absolutely exists. Hyperalgesia, increased sensitivity, which I see, and I'm sure you see a significant amount of. And what do these things all have in common? A lot of people have anxiety, depression, sleep disturbance. A lot of these things come hand in hand. And presently, most of the things that we use today, no matter what modalities that most of us have had in the past, pain reduction was minimal to practically or short-lived. And I'm going to tell you, if you take this opportunity to really take advantage of the cerebrolysin I've discussed with you, it's going to change your practice forever. And your patients are going to tell other people about it. It's just a great utility that is, it's really been fantastic for me over the years in what I've been able to do and how I've been able to change my practice and really helping people that, I see it all the time, people that come in with years of pain and you can, with one injection, I've had so many of those, one injection, these people come back a week later and said, I can't believe that made a difference. And let me give you some, I've had a lot of experience with it. I will tell you, I've had a couple people. I had a guy that I just recently saw that he had lower back surgery, spinal fusion, musculoskeletal pain, which is most of the time what it is, lower back, SI joint kind of thing. And I injected him with, he had like over 10 years of problems. I injected him, and one time he came back, he had the best week of his life. He could not believe that what I did or how it worked. He just didn't think it was possible. The guy came in on a cane. He left without a cane. He came back without a cane when he saw me. And I said, all right, well, let me see you again in another week. He came back another week and he was in pain again. But the problem we got into is, so this guy was I think seriously deconditioned, didn't take any time now to follow with what I wanted to do to build up his back musculature, started doing things like, chopping wood, all kinds of things he couldn't do before. and he was in some serious pain when I saw him again. And I think he just significantly overdid it. And I said, well, we'll get you out of it. And I tried the cerebrolysin again, came back. He said, Doc, I got 1 day to 2 days of relief, and then came right back. And I'll tell you right now, I'm in the middle of trying to get him back to normal. And I've seen him 5 times, and I have not been able to get him back to where I had him before. So I still make mistakes in not thinking ahead of, I'm too enamored of the results and I'm too excited that they've gotten better. And I'm forgetting that, oh my gosh, you've had somebody that's come in totally deconditioned. You've taken their pain away, and then you've given them a, that false sense that they can do things that they couldn't do before. And you gotta make sure I'm going to tell you, please make sure you pay attention to that and get them in the right place to get conditioned back, and to do it slowly so you can take advantage of what you've done. And I think you can do a lot more with that. So therapies, we've got them all: physiotherapy, cognitive interventions, interventional therapies, spinal cord stimulators, anticonvulsants, antidepressants, opioids, topicals. We've tried all these things, and I'm going to convince you that, or not convince you, you're going to convince yourself by just taking that step, and then get back to me on the forum. I'd love to hear more results. I've already heard, some people that have already been telling me how they've been doing since I was down in Florida and presented this. I mean, the results have been amazing already with people sharing their stories, and thank you for that. But I'd really prefer it if you put it on the forum, because then people get to see that too. So neurogenic inflammation, peripheral nerve injury triggers spinal inflammatory response. That releases the fractalkine, the chemokines, and tumor necrosis factor. These are all signaling agents that cause this inflammatory response that starts with a peripheral nerve trigger, but it starts a spinal inflammatory response. And then these macrophage and microglial cells and monocytes can undergo a phase change and continue to activate the peripheral nerve at that spinal cord level, right, at the dermatomal level. And that's where the microglial cells and the astrocytes actually will migrate to that area of the dermatome in the spine, and they'll be activated and continue this inflammatory process. And that's where we get caught up in this chronic pain cycle. And this is just talking about how you can follow CFOS is a protein made by the immediate early gene expression, which is something that's followed in pain, and that's made by the astrocyte. So neurogenic inflammation. So this is, I think, what's important is, so we want to inhibit the activated inflammatory cells in the spinal cord. Well, to do that, so what is happening is there's this transient receptor potential vanilloid 1. It's the TRPV1, and this is what initiates and maintains this nociceptor neuron process. And the nociceptor, so the nerve, the unmyelinated C fiber, will initiate it, and then the activated microglial cell in combination with the astrocyte will maintain and amplify and keep this transient receptor potential open. It'll keep this channel open, and that's what continues this cycle. And just interesting how this inflammatory response in the spinal cord can move from cranial in the caudal direction, and it's why you can get lower dermatomal levels that spread. You can get contralateral dissemination. So you have those patients that say, well, my pain's here and my pain's also over here, and people think they're crazy, and that there is actual there are real pathways to why it's happening, and it's secondary to this contralateral dissemination of the inflammatory process. So the mechanisms to relieve this is, what are we trying to do? We want to get rid of that activated microglial cell response. Now, some of you might be thinking, wow, activated microglial cell, couldn't you use TA1, thymosin alpha 1, systemically to try to treat that microglial activation? And the answer is yes, you could. And actually, I will tell you, I had a couple recalcitrant patients, and that's what I'm getting ready to use on this gentleman that he reactivated himself. But I think sometimes the immune system needs a little more help. And this is where TA1, and I didn't put that in this presentation, but I think it's just something to bring up. And you guys are smart enough and savvy enough now to understand this is where the art comes into play here of, okay, look, I can stop this peripheral nociceptive process. I can work on also trying to decrease the reflex arc in the spine with the cerebrolysin, but I might need some more help with this microglial cell activation, and TA1 can really be helpful. Or you combine it with the TB4 and the BBC. So there are lots of ways you can go at this, but just something to keep in mind and great discussion to have in the future. So another thing that I think is real important, and I said this would only go 15, 20 minutes, and of course I'm already half an hour. I'm sorry, guys, but I'm almost done. And this is getting to what I've found to be just fascinating in when you're working with neuropathic pain is this other response receptor. It's called the innate immune response receptor. And this is a secondary to tissue injury. This receptor will not be activated unless there is injury. And what has been found is that around this innate immune response receptor, you can produce your own erythropoietin that is in an autocrine paracrine type of fashion that can be protective and can mediate this activation of inflammatory response of this pain process where the tissue injury is by controlling this innate repair receptor with your locally produced erythropoietin. And that's produced by hypoxic inducing factor, transcription factor. It activates the metabolic pathway to restore that cellular integrity by releasing its own erythropoietin. So I'm gonna just lead you down the pathway of understanding what is this innate repair receptor. This is a fascinating receptor that is not expressed typically in normal tissue, but it's upregulated in response to injury or hypoxia or stress, and it has a specific affinity for erythropoietin, and you need high concentrations of it around that area to have and activate the tissue repair pathways. And I'm going to show you a great slide that you can refer back to give you more information about it. Well, let's just jump to it. Because this innate receptor comprises a CD131 and an EPO receptor. They're kind of two subunits. But what you can see is this innate receptor is typically not identifiable until there's stress or injury. Then it shows itself, and typically you will make your own erythropoietin to control this receptor to then activate your own tissue repair, decrease inflammatory response, decrease apoptosis, all the things you've learned from me in the past about controlling inflammation and the innate immune response. You have the capacity to do this with this receptor. And what happens is you just don't make enough of the erythropoietin, or you can't keep up with the injury itself. And this is become a target of what we have a specific peptide, because what we found is that exogenous erythropoietin, recombinant, has a significant effect on reducing pain, significant effect on this innate repair receptor. The only problem is we know by using erythropoietin, you have some serious side effects that can happen: hypertension, stroke, and myocardial infarction, thrombosis. I mean, all the bad stuff you don't. But recombinant EPO is amazing in taking care of pain. And we learned it through this innate repair receptor. Well, what do? You go in and you find that fragment that is specific for the innate repair receptor, and we did it. And it's ARA290. It's an 11 amino acid chain, and it has about a 20-minute half-life, and it will activate that receptor, and it does cross a blood-brain barrier, so it works peripherally and in the brain and in the spinal cord. And it also promotes repair of a smaller autonomic nerve fiber. So like in type 2 diabetics, with peripheral nerve aspects and loss of unmyelinated C fiber, you can actually make new C fibers. You can improve sensory. Yeah. Incredible, right? That's just incredible. And those are some of the things that I can see with cerebrolysin. I can see it with TB4 and BPC, but I'm even more excited about this peptide. And what this does is it works on that TRPV1 channel, and it stops that channel from, it shuts it down from the continued reactivation. And it also promotes repair of the autonomic nervous system. What's also interesting that I didn't include here is in the studies with the diabetics is it improves glucose tolerance and insulin sensitivity. And also improves, obviously, if you're improving that, you're going to improve vitality, energy, you're going to decrease fatigue. So this peptide has some significant relevance. And in the studies, they used 4 milligrams, was administered daily for 4 weeks. And we are going to hopefully see that peptide available for us. We're working on getting that available very soon. And this was just to show you this. So the cornea is the most sensitive for unmyelinated nerve fibers. That's why it's so sensitive, right, to scratches and so forth. And you can actually follow the improvement in microscopically of quantifying these the production of these small fibers, these unmyelinated fibers, by being treated with this ARA290. So I was just showing you how the targeting of this innate repair receptor can treat neuropathy, and I think that's going to be just exciting when we have it available, as we've seen in clinical studies, as this is done really well with no toxic effects, no issues other than improvement. So I'm very excited to have this on top of the other things that we're already using. And like I said, I mean, I think we're going to we should be able to make a whole day course out of cerebrolysin and what it can do for pain. I mean, it's just been incredible in my hands, and I hope it does the same for you. And I hope you guys get the opportunity to share your stories and your results and your patient outcomes with everybody on IPS. It's been so exciting working with all of you in all of these strides we've made with everybody involved in trying to learn more in helping our patients. And again, I'm humbled to be able to talk to you and to share just my thoughts and ideas with these pathways and involving these type of peptides and the peptides coming down the pike. So thank you.